outpatient. Dr. Rajneesh, I'll throw it over to you to maybe introduce some of our panel members, and then we can go through some of the questions and if you had any sort of take homes that you'd like to add regarding the case.
Yeah, sure. Thanks, Souvik. So this was one of the many cases which we had during the second wave. And we chose this case deliberately because it's not a perfect case. There are many pitfalls and there are many misses we had and I would like to highlight them before we move on to the panel very quickly. Firstly, his pre-hospital course, he received azithromycin and paracetamol, which is usual, which was given to practically everyone who was coming with fever. And this was a rush of OPD as well as emergency time. Because our emergency is full of people who were otherwise having breathlessness and oxygen requirement. Now, once this person had oxygen requirement, he was in ER initially and then moved to the ward. And we can continue to argue that there would be certain therapies which maybe given early would have been helpful, something like remdesivir. But we also had numerous situations during the same time period when we were giving loads of remdesivir to many patients who did not survive. So that's one we can call as a pitfall why it was started later. This person also received methylprednisolone and in fact all did receive loading dose of methylprednisolone early on, which could be another issue which we can argue. Now, despite receiving I'll say adequate doses of steroids, he did continue to worsen and eventually reached ICU. Like many of our patients who reached ICU despite or in spite of receiving various therapies. And then we come to issues about which therapies we should really prioritize when we are talking about cytokine storms worsening. And in fact, this person probably was in cytokine storm the day he reached ER. And his storm and oxygen requirement continued to worsen while he reached intensive care unit. Good part of this case is that he survived and demonstrates that good ICU care is paramount when patients land up in much worse state. And it's a lot of patients and a lot of ups and downs are really there once patients in their journey from intubation to extubation and weaning. We had this particular patient coming for a follow-up the last week, I'm told, and he's doing fine, and he came walking, and that's really joyous to all of us. So we have 4 panelists here. Dr. Sunaina Tejpal-Karna, who is an associate professor in Department of Anesthesiology. Dr. JP Sharma, who is professor in Department of Anesthesiology. Dr. Saurabh Sehgal, who is additional professor in same department. And these 3 of them have worked kind of really hard during the COVID pandemic and were kind of pillars as far as ICU support was concerned, especially during the second wave, also in the first wave. And we have Dr. Lokendra Dave, who is head Department of Respiratory Medicine, GMC Bhopal, and currently also medical superintendent there. He's also the nodal person for the state task force for COVID-19 right from the beginning of the first wave. And I welcome all the panelists here. And with kind of these challenges and these background to the case, I'll, I think, request Souvik to let's initiate the key issues which we have in front of our panel today.
Thank you so much, Dr. Rajneesh. I would echo the thank you for everybody for joining. I'll also add for the experts that are on, please keep in mind the chat and any questions that are there, and feel free to answer them. For the sake of time and to streamline sort of our ability to, again, take this overwhelming topic and disease and try to narrow it down to some more focused questions, we have a few here. And Dr. Lokendra, we'll start with you with the pre-hospital course. And really our first question are drugs like ivermectin and favipiravir indicated in this situation? And if you'd like to answer sort of, this particular patient's pre-hospital course with the azithromycin and its use there, we'd be up to hear that as well. And Dr. Lokendra, I don't know if you're on mute. I can't hear you.
Yeah, I think Dr. Dave, I saw him in the participant list. So I think by the time he's joining, uh, yeah, various
Why don't
guidelines.
we can
Yeah,
turn it over,
yeah,
perhaps Dr. Sorab or one of our other
yeah,
experts, if you'd like to take that one.
yeah. We can move on to Dr. Saurabh, who could answer these questions, and I think also move on to other issues related to steroid use. And many people are asking similar questions in the chat box.
Yeah, so why don't we take that then? So Dr. Sorab, would you like to tell us about the oral steroids prescribed early in some situations, particularly in this patient, and then the dose and use of steroids that we had in this patient with the
So as
methylprednisolone
you can see,
specifically?
this patient came at around day 6, day 7 of illness. And at that point in time, when he reached our emergency, his saturations were 90 or around 90, that he was requiring supplemental oxygen to improve his saturation. So he classifies as a case of severe suspected COVID. And it was a pandemic situation where 10 out of 8 patients are coming COVID positive. So the use of just waiting for report for one day and delaying steroid, that becomes wrong. So the use of steroids was justified in this case. Now coming on to the next part, whether to use high dose methylprednisolone or not, again, as per recovery, remap cap, all studies have recommended dexamethasone 6 milligram. What we have been using in our institute is around methylprednisolone 1 milligram per kg BD dose. Uh, just probably high dose steroid would have been given just to blunt the immune response. So I think so the high dose was not justified, but again, probably the intention was to just to suppress the immune response. Good thing was that the high dose steroid was given when the patient was on oxygen or just like non-invasive. Giving high dose on mechanical ventilation is detrimental. So probably there was some logic, but again, high dose as of now, it's not recommended.
Right, and so just some like the sort of bolus dose is probably not necessary in some of these patients, but the early use of steroids is a helpful mediator, and I think Dr. Allwater will be able to help us with some of the data behind that. Dr. Karna, I want to move to you and talk about remdesivir. And is remdesivir essential? And then when is the best time to institute it? And then also, of course, we can specifically comment on this case and the timing.
Namaskar. Remdesivir, I would say, is definitely essential. It is one of the very few antiviral drugs which has shown some promise in treatment of COVID-19, though the initial trials were not very supportive. But as a practice, once the patient is hospitalized and logistic issues like availability of the drug is not there, we usually give remdesivir. So that is our standard of practice over here. And in ICU, once the patient is on oxygen support, NIV, even high flow, that time also we do start remdesivir. Sometimes patients come intubated. They have been through different hospitals, nursing home, and that is the time when they come here. That time you have to think if the patient is tubed and it's been a long course, that time remdesivir, you have to think whether it is going to be really beneficial. And you have to look at the contraindications, whether it is justified giving it. But on the whole, I would say that in India, in the pandemic scenario, we have to pursue soft targets like time to recovery, early discharge, freeing up ICU beds. So in this clinical scenario, to come back to the question, remdesivir is very essential. When to administer as early as possible. In fact, real world studies in India have shown that starting remdesivir after symptom onset of, say, 8 to 9 days has shown better outcomes in terms of reduced odds of mortality. So, starting as soon as possible after hospitalization of the patient.
Great, thank you for that. And just to add a little context, I was just in the ICU this morning, and we have a new 31-year-old who's on high flow oxygen. And the two questions I asked are, is he on dexamethasone and has the remdesivir started? And thankfully, both of those things were done. But I think, as you both indicate, those are key to the management of the COVID-19 patient and should be done sort of on the earlier side. Dr. Karna, I want to stick with you and talk about tocilizumab and the IL-6 inhibitors and
I can't hear you. You're muted. Dr. Shavik, your mic is muted.
Yeah, I keep getting muted for some reason. I think I'm unmuted now, but I was saying, so Dr. Khan, I wanted to, maybe we can stick with you and go with the IL-6 inhibitors, tocilizumab, their utility and when to administer, because if I recall the case correctly, I don't think this patient received tocilizumab.
So we are a little skeptical about giving tocilizumab in our hospital. In the first wave, I think we used it in quite a few patients. And though initially it showed promise, we realized that it really suppresses the immune system. And many of the patients landed up in sepsis. So tocilizumab is a good drug, but the window period to give it is very limited. It has to be given within the first 3 days or 2 days of ICU admission or worsening oxygenation status. The thing is that in a pandemic scenario, not everybody who is needing high oxygen support will land up in ICU in case the ICU beds are full. So even in ward, many a times Dr. Joshi would be discussing that I'm starting this patient on tocilizumab and keep an ICU bed available as soon as the bed is freed up. So in that scenario, I would say that tocilizumab has benefit when there is evidence of cytokine storm, the CRPs are raised, there is no evidence of sepsis elsewhere, and it's been just in the initial stage, not later on, not once the patient is tubed or patient is in sepsis. That time it's a double-edged sword. So it is not good to give tocilizumab then. But yes, in some patients, we have seen improvement when it was given in that particular window period. So it is not just about the drug, it becomes more important about the timing of when you are giving that particular drug. So with tocilizumab, we have been very careful in which patients to use. Like I said, if there is cytokine storm in initial phase of increased oxygen requirement or patient landing up in ICU in the initial 1 to 3 days, we used to give tocilizumab.
That's great, and I'd say that that completely sort of mimics our practice here at Hopkins. It is timing specific and it's patient specific, but it's certainly not for everybody. Dr. Sharma, I want to move to you, and sort of as we with our case move from the outpatient, the emergency room to the floors. Are there any COVID-19 specific agents that are most useful for patients that are on an invasive mechanical ventilator?
Good evening, everybody. Swabik, once patient goes on mechanical ventilation, till now, more than 1 lakh publications has been there on COVID-19, but still, once your patient goes on invasive ventilation, there are no COVID-19 specific agents. The corner of the management remains, cornerstone of management remains, the ventilation, oxygenation, and infection control. Probably low dose steroids if the patient has come in first 2 weeks, and anticoagulants.
That's great, thank you. And I think this case also demonstrated the value of lung protective ventilation and closely monitoring how patients doing on the mechanical ventilator. This the steroid question, of course, is has a long history in critical care and a long history in ARDS, and now a shorter history with COVID-19. In your expert opinion, how long should steroids be given for the inpatient management? When someone is pretty sick and stuck in the hospital.
Like this question has to be answered. As I told you, 1 lakh of sort of publications, but still answer of this is not certain. And but I see there are many of the 3-4 randomized control trial and many observation studies. Most of the time, I think if you refer to recovery trial also, it is around 7 to 10 days most of the time. But there are few studies which says up to 14 days as well. And there have been only few, like maybe 2 to 3, which I could see it 21 days. But those are observation studies. But recent we had a meta-analysis of around 15,000 patients, which shows 21,000 patients, which shows that if we go for a long duration with the steroids, even the outcome may worsen. So again, it's remain a double sword edge. So we have to use it very judiciously, and I think whenever it has to be used in a low doses. So we want to, suppress the immune response, not the immune system.
I think that sounds very reasonable, and there is this tendency to want to give as much drug and more drug, but that is not always to the benefit. And I'd say I think that is also very consistent with our practice. There are times where we'll run it a little bit longer. There's times where someone will be off steroids and then we'll restart steroids, but we always have to monitor for the response and consider the risk benefit. And you're right, it is a double-edged sword, but we certainly shouldn't be continuing it long term.